So the impact of the criteria was colossal, allowing an earlier and more precise diagnosis of MS. And I think that the consequences of McDonald diagnostic criteria have been really remarkable. So I think that one of the most important statements is that dissemination in time is not longer needed. And I think this is really key. On one sense, we are trying to make the diagnosis very early on. On the other hand, we are treating our patients, and one of the objectives of treating our patients is not to have dissemination in time. With this criteria, we do believe that may be easy for some of our colleagues working in other areas around the world to make the diagnosis fulfilling the criteria. And I think that will be a very helpful tool for our patients. My name is Xavier Montalban. I am the head of the Department of Neurology at the University Hospital in Vall d'Hebron, Barcelona, the director of TEMCAT, which is the MS Center of Catalonia, and the chair of the International Advisory Committee on Clinical Trials in MS.
And I'm Brett Drummond. You're listening to the ECTRIMS podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. The features of multiple sclerosis were first defined by Charcot in 1868. While the understanding of MS changed significantly over time and many different diagnostic systems were implemented, it was in 2001 that an international panel, led by neurologist W. Ian McDonald, met to devise and recommend revised diagnostic criteria for MS that became known as the McDonald criteria. These criteria were updated in 2005, 2010, and 2017. Currently, discussions are taking place to revise these diagnostic criteria again, and my guest on this episode, Xavier, has been instrumental in these conversations. Xavier, thanks for joining me.
Thank you very much, Brett. A pleasure.
So I think before we get into what was discussed at the meeting, I think it would be interesting for people to know a little bit about who was at the meeting and who was discussing it. So can you tell us exactly what the International Advisory Committee on Clinical Trials in MS is and what their role is related to these diagnostic criteria?
Right. So the International Advisory Committee on Clinical Trials in MS is a global body sponsored by ECTRIMS, as you know, is the European Committee for Treatment and Research in Multiple Sclerosis, and also sponsored by the US National MS Society. And it is composed of top experts, I would say, in the field of MS, not only neurologists, but also scientists and patient representatives. I think you know, but the committee has been existing for over 30 years now and has developed the McDonald diagnostic criteria starting in 2001, as you said, and also was responsible of the 96 and 2013 clinical course descriptors for MS, among other important topics. So quite a relevant role in the MS field.
And so I guess I sort of already mentioned it in the introduction a little bit, that the McDonald criteria have undergone a number of revisions since they were implemented in 2001. Can you talk us through what some of the main changes have been? How have the criteria evolved through those successive revisions?
Right. So the first papers, in fact, describing the role of MRI in MS were published in 1998 by Don Beatty and Franz Verzeker, respectively. And then the McDonald diagnostic criteria incorporated the MRI. I think this is the main value of the McDonald criteria, which is, as you know, the key tool for the diagnosis and monitoring of multiple sclerosis. And that happened first time in 2001. And we had a number of revisions, as you said before. So the impact of the criteria was colossal, allowing an earlier and more precise diagnosis of MS. And I think that the consequences of McDonald diagnostic criteria have been really remarkable. And I would just mention a couple of things in relation to this. So by anticipating and facilitating the diagnosis of MS, we have improved the prognosis in the long term. So as an example, we published in 2021 a paper in neurology showing that since we transitioned from the Poser criteria to the 2017 McDonald criteria, we decreased by 77% the median time from CIS, that means first episode suggestive of multiple sclerosis to MS diagnosis, and by 82% the median time from CIS to treatment onset. And as a consequence of these factors, the probability of reaching an EDSS of 3, which is a disability scale, or higher at the age of 40 has decreased from 0.86 to 0.2. So I think this is really key, and this is the important aspect for our patients.
Yeah, I mean, definitely when one of the key messages coming out of conferences that we've been to over the past couple of years at ECTRIMS has consistently been getting people onto highly effective therapies as soon as possible has a big impact on their long-term outcomes. Obviously, the earlier we can diagnose, that's obviously going to play into that. So I guess moving forward to the most recent meeting and the decision that, these criteria needed to be updated again, what was the thought process behind the fact that there needed to be another review?
So we realized that quite a lot of evidence had been generated over that 6-7 year period. So we wanted to incorporate some rational improvements and also incorporate some new elements in the diagnostic criteria. And then we had a quite careful process to prepare the revision. If I can describe this process for you. So the committee leadership proposed reviewing the 2017 criteria in 2021. And then during 2022, a number of topical reviews were done by clinical trials committee members. If I remember well, we met 3 or 4 times during the 2022 period. And then in 2023, sponsors approved the revision meeting, which took place in Barcelona from November 29 to December 2nd. And we had a meeting in Barcelona with 56 international experts with expertise in clinical management, radiology, methodology, epidemiology, and patient perspective as well. We met there. I'm very proud to say that we had a global representation with 16 countries from 5 continents, and we were 23 females and 33 males. At the meeting, we followed a consensus methodology. I think that was the first time we incorporated this into the McDonald criteria meetings. And then we presented the proposed revisions and supporting evidence with general statements, specific recommendations, and we voted all the statements. 90% of meeting participants were required for every specific voting, and we require 80% agreement to be accepted. So that was quite a careful procedure during the meeting.
I mean, it's obviously not a small thing to change these criteria. It's obviously going to have a big impact for neurologists and healthcare professionals around the world. So it's quite a responsibility for the group of people to take on. Before we move into just talking about some of the specifics, I'm just interested in just talking about the rationale just a little bit more. Obviously talked about the importance of early diagnosis. Is part of this revision to try and get even earlier in terms of diagnosis? What's the role as well in trying to separate MS from MS mimics, which we've seen talked about a lot more recently, and trying to avoid misdiagnosis or more accurate diagnosis? How do both of those things play into needing to do these revisions?
Well, this is a very important point, Brett. Of course, on one hand, we want to ease the process of diagnosis, not only in Europe or in North America, but also in the rest of the world. So, and this is not trivial at all. For that, we have to simplify the diagnostic criteria, and we would like to make the diagnosis, as you said, earlier. However, on the other side of the balance, we need to preserve the specificity of the diagnosis. And we are very much aware that sometimes there are misdiagnoses, and we don't want those, right? So that was the key element of the whole procedure. So increasing sensitivity, facilitating the diagnosis while preserving specificity.
Just another follow-up question to that. As you mentioned, it's sort of criteria that need to be implemented worldwide, and obviously access to healthcare differs greatly across the world. How difficult is that when you're coming up with these criteria to try and make them as inclusive as possible for people in various regions?
The difficult thing is the solution for that problem. So, we will have always differences in the clinical care in general in developing countries in comparison to others. So that's very difficult to fix. But with this criteria, we do believe that it may be easy for some of our colleagues working in other areas around the world to make the diagnosis fulfilling the criteria, and I think that will be a very helpful tool for our patients. We will see. So they will tell us if this is the case after 1 year or 2 years of implementation of the 2023 diagnostic criteria.
Okay, fantastic. So moving on to, I guess, what was discussed at the meeting and what some of the outcomes were. Can you talk a little bit about some of the specifics from itself, I guess, in terms of the main outcomes of that in relation to the criteria, understanding that a lot of these outcomes aren't public yet, and I know there's plans to do that at some point, but if you can share with us what you can at the moment, that would be great.
Yeah, I can share with you general statements. So I think that one of the most important statements is that dissemination in time is not longer needed, and I think this is really key. On one sense, we are trying to make the diagnosis very early on, and on the other hand, we are treating our patients. And one of the objectives of treating our patients is not to have dissemination in time. So not to have new T2, new relapses, whatever, new progression, etc. So there is no sense to keep dissemination in time as a requirement to make the diagnosis of multiple sclerosis, and this is not going to happen anymore. So I think this is important. Another aspect is the need of preclinical evidence to diagnose multiple sclerosis. If you have a look to the previous diagnostic criteria, you realize that you may make the diagnosis of multiple sclerosis just by clinical means only. Now, in 2023 or 2024, as we are now, this looks a little bit, strange. So I think we will require the preclinical evidence to diagnose multiple sclerosis. It's very difficult nowadays to make the diagnosis of multiple sclerosis in a patient with a completely normal brain and spinal cord MRI, just to give you one example, right? So another aspect is the inclusion of the optic nerve as a fifth typical topography, which makes sense. 1/3 of our patients start with an optic neuritis, and almost 100% of our patients will have optic nerve involvement over time. So to include the optic nerve as a typical topography makes all the sense. Another aspect is that we updated the DIS criteria, the dissemination space criteria. We will specify how we did that. We also consider the addition of specific MRI signs, such as CVS, central vein signs, and PRLs, paramagnetic ring lesions, as optional tools in some specific situations, but only in some specific situations. And I think another key element that we reviewed is the incorporation of RIS as MS, right? So radiologically isolated syndrome, that refers to patients who don't have any clinical symptom suggestive of multiple sclerosis, but they do have a very typical MRI with demyelinating lesions. This is I wouldn't say common, but not uncommon situation in the clinical practice. And now with the new revision, some RIS will be labeled as multiple sclerosis, and I think this is a big thing. Yeah. On the other hand, and just to preserve the specificity, we will require, we will be more strict with patients over 50 years and also patients with vascular disorders. So we will be a little bit more demanding for those patients, just to avoid misdiagnosis. And the last point that perhaps I would like to mention here is that we will incorporate the kappa-free light change as a tool for diagnosis of multiple sclerosis. And in some labs, the determination of oligogonal bands is not easy. It's not a trivial procedure. So I think that will be a very helpful tool in some labs around the world.
Fantastic. I mean, really interesting, and obviously a lot of thought and work has gone into putting all of this together. And it's exciting to see how things have gone from a lot of the things you're talking about. There are things that, having attended ECTRIMS conferences over years, have been things that have been building and being talked about in this space. And it's fantastic to hear, how they developed to now being included in these criteria. So I guess sort of to finish up, what are the next steps now for the committee in terms of implementation, talking about these more broadly? Are there plans to release these at upcoming conferences? Is this something we can look forward to in Copenhagen later this year?
Yes, now the manuscript is now in preparation, and the new criteria will be fully presented at the ECTRIMS in Copenhagen this year at the ECTRIMS meeting. So I think that would be the first time that all aspects will be presented in public. And then we plan as well to implement some additional papers to facilitate the understanding and practicability of the criteria around the world. So a number of initiatives together with the National MS Society and ECTRIMS as well will be set up.
Okay. Fantastic. Well, look, it's obviously an immense amount of work. So thank you to yourself and the rest of the committee for putting the time in to do these revisions that obviously will have a big impact on the diagnosis and subsequently the treatment and management of multiple sclerosis. So thank you for that, and thank you for making your time to discuss these with us on the podcast today.
My pleasure. Thank you very much.
And thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode. I'm also co-founder of MS Translate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community. The ECTRIMS podcast is produced and hosted in collaboration with two key partners, MS Translate and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The ECTRIMS podcast is supported by an educational grant from Novartis, Roche, and Alexion AstraZeneca Rare Disease. Educational grant providers have no input on the podcast series content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS podcast on your favourite podcast channels and follow ECTRIMS on X, formerly Twitter, LinkedIn, Facebook, and YouTube.